Thank you very much for the kind introduction and for the invitation. It's a pleasure to be here and present on the work. I pointed to the big data, in which big stands for biomedical imaging and genetics in this case. The words, the letters fit. And also would like to make links to the developments in this field that are disruptive in part of our field already, and I hope they're going to be disruptive in a larger portion of our field. So actually it's also a little bit of a challenge to the community to see whether the enormous leaps in performance we have seen in imaging tasks, whether they can carry over to imaging genetics tasks. And few people start to work on it, but actually it's not many people yet that work on that. So there's, I think, a lot to do. So there was a referral in the introduction of this workshop to the RSNA. So it's quite interesting also that not only this conference has grown so much, but also I've been going to the RSNA and the ECR, which are the main radiological conferences for the last 10 to 15 years. And we, as a community, have been presenting a lot of methods in order to quantitative analysis or more objective diagnosis. And often sessions related to that were planned on the Friday morning when everybody has left the conference. And now it's really the keynote talks at the beginning of the conference, and even in the industrial exhibitions, there was now a machine learning section. There were about 40 startup companies and scale-up companies presenting their work. So it's really making a big impact in the radiological field. And a lot of people realize now, and they actually do, most visionary radiologists really embrace this development rather than fear it, although they also have questions whether they should train the same number of radiologists now and whether they should train them the same way as they do. But I think they need to embrace it because getting to a data science approach in radiology, medical imaging, and imaging genetics will get us to precision medicine. So in precision medicine, that's really what we would like to achieve. We would like to take the individual variability of the person and of the pathology into account to tailor the treatment to the individual. And really, in daily clinical practice, we are very far away from that at this moment. For example, if we look at cardiovascular diseases, one of the imaging biomarkers that made it to the clinic and is being used as a decision criteria now is if you're symptomatic and your carotid artery is closed for 70%, then that is a sign which indicates that you will undergo treatment. But we know that we're actually treating 6 patients to prevent 1 stroke, and we're missing more than half of the strokes. So this is an imaging biomarker, it's a predictive biomarker, but it's definitely not a very good one yet. In cancer treatment, we know more and more that it's the molecular basis or the subtype of the tumor that determines whether the therapy is likely successful. And there is more and more promise that actually we don't need invasive biopsies, but that we can use imaging features with radiomics techniques or deep learning techniques to characterize the tumor and try to predict a response to treatment. I will come back to that later in this presentation. And also in dementia, there's large challenges to use big data. For example, the one from UK Biobank, I will present data from a different study in order to do a better job of doing early detection and prognosis of dementia. At this moment, the time in Europe between getting the diagnosis or going to the general practitioners and having memory complaints and having the definite diagnosis of the subtype of dementia takes on average 20 months, which is associated with a lot of costs in the diagnostic process and also a lot of uncertainty with the patient and relatives. So I would like to go into dementia and cancer and the role of machine and deep learning a bit deeper now. So dementia, of course, is a terrible disease. This is an example from an American artist, William Petromoden, who had early onset Alzheimer's disease. And he kept on taking pictures of himself during the course of the disease. And you see the dreadfulness of the disease in his inability to paint at later ages, and also you see the mood of him reflected in these paintings. So it's really a big societal challenge and all over the world to deal with dementia. And there is some promise that we can at least work better to detect dementia earlier and do some prognosis. So this is a hypothetical model. If you go to Alzheimer conferences, this will be shown in every second or third talk. And it shows that if you age, at a certain point of time, if you get a neurodegenerative disease, you first start with cognitive complaints, that you or your environment will detect. But we know now from many studies that there's a number of biomarkers that are elevated years before we get the disease. So in principle, this would give us a window of opportunity to detect the disease at an earlier stage, do a prediction, and try to support preventive strategies. At the moment, the number of preventive and intervention strategies is unfortunately still limited, but even now is knowing what subtype of dementia you have is improving your quality of life because you get more tailored treatment. So we're doing this in the Rotterdam study. So the Rotterdam study is a population study like the UK Biobank. It's been running already for 1990, and since 1995 we're also collecting imaging data in the Rotterdam study. And it's really important, these population studies like UK Biobank, and now in Germany you also have the national cohort, and you have the Rhineland study, and the Framingham study on cardiovascular diseases in the US is an example of it. It's really important because we have to realize that all the information we have in the setting of the clinic, or perhaps in terms of screening studies, is of people that already have the disease or have a high risk of disease. And in order to understand the development of disease years before you contract the disease, you need to start to collect data of a cross-section of the population, follow them over time in order to be able to look back into the determinants of the disease. So what is then the design of a population imaging study, like the UK Biobank or the Rotterdam study? First, you try to collect as many risk factors as you can. So genetic data can now be acquired at low cost and a very high resolution. So you get very detailed genotyping of all the participants in these studies. We try to collect all lifestyle factors, what education they get. You have their zip code, you know whether they're close to an electricity line, you know what drugs they take, their dietary habits. So you try to collect as many as possible risk factors over time. And in a classical population study or epidemiological study, you will relate these risk factors to outcome in order to try to build predictors. But this is, of course, quite a black box. And this black box has now been filled in by imaging. So in these studies, increasingly, we do large-scale imaging. So we have been scanning people now every 3 to 4 years. They come repeated to the center, and we follow over time whether they develop disease or whether they age healthy. So then is the question, can an approach in which you do then data science, in which you try to collect information from the imaging data to do prediction, can that succeed? And there is some evidence for that. This is a study which we did in 1,000 participants of the Rotterdam study, in which we automatically segmented the white matter lesions. And white matter lesions have been associated with an increased risk of dementia and an increased risk of stroke. And we look at images 4 years apart, and we try to look into the tissue, which was normal at the baseline scan, and which turned into a white matter lesion 4 years later. So we use image glow registration to register the images at the two time points. We automatically label the white matter lesions, and then in the white matter you can identify 4 regions, those regions that stay healthy over the 2 scans, those regions which were already the white matter lesion at baseline, and those regions in which the white matter lesions have grown or in which new ones appear. And then we just did a simple statistical analysis of all the MR sequences, the fusion MR, FLAIR data, to see whether there are statistically significant differences in the data that turned into the white matter lesions later on. So here you see one result, which is just on the fractional anisotropy with diffusion tensor MRI, in which you indeed see that years before a white matter lesion is observed in a conventional image, which is normally used in the diagnosis in radiological practice, that the normal white matter, this image signal is the same, but in those regions that turned into a white matter lesion, already years before we saw a change in signal. So apparently in all these MR images, there is some changes, there is some underlying disease process going on. And that's what we're learning by many studies, that there's microvascular disease, all kinds of disease processes going on in the brain at the microstructural level, years and years before you have symptoms and years before these diseases show up in conventional imaging. So it really makes sense to start a big data science approach in which you collect many of these high quality data and relate them to outcome. So that's what we've done now on about 14,000 MRI scans. And this work all started before the revolution in deep learning. So the way this was approached, that we made standardized image processing pipelines in which we segmented as much of the structures we could, the brain tissues, the different neurostructures, the white matter pathways. We tried to quantify all the vascular pathologies in the brain in a fully automatic, standardized manner. So this gives you a library of quantitative imaging biomarkers, and then with conventional machine learning, we use that in order to do prediction, to see whether we could predict whether someone could get dementia or not. So interesting, since the breakthrough of deep learning, what has changed in this kind of study? So these were already studies in which we had big data, we did automation, we followed people over time. So in a way, these studies are very well suited to profit from the advances in the domain that this conference also covers. So first, we see that one by one, we're replacing all the quantitative imaging biomarker extraction algorithms with deep learning versions. And in most cases, because these are quite controlled studies, these algorithms outperform the current state of the art. Also, we started to be able to segment a number of imaging biomarkers that we could not segment until now. One example is actually the enlarged perivascular spaces. These are fluid-filled spaces around the vessels that are early in microvascular disease, and they show up as very small hyperintensities on the MR scan. Very difficult to distinguish, very difficult to label. But we are in the lucky situation that we co-work with an epidemiological study in which they were very interested in the role of these enlarged perivascular spaces in the early stages of neurodegenerative disease. So they actually have been labeling thousands of these scans. Actually, these scans have only been labeled with a weak label. We only know how many of them there are in the scan. They have not been localized. So based on that, we have trained a convolutional neural network, which was followed by a regression in order to try to estimate the number of enlarged perivascular spaces in the data sets. And after a number of iterations to improve the network, we now achieve a performance that in most regions is challenging the human performance. So this is a task that we can now do automatically owing to deep learning. The next, I would like to discuss a bit the developments in the field of oncology, because we also see that there, from the imaging domain and the image analysis domain, there has been an evolution which very well makes this field of research open to also profit from the progress in deep learning approaches. So radiomics became popular a few years ago by a paper in Nature Communications by a group in Maastricht. And actually, from the aspect of machine learning, it was not a very high quality paper, in the sense that it just computed a number of features and in a very ad hoc way tried to define whether these features related to subtyping of tumors and to outcome. But because they did it on such a nice data set and that they really showed that multiple features were related to patient outcome, it really started a big field in radiotherapy and in radiology in order to start characterize tumors better with the radiomics approach. Now, the idea of the radiomics approach is the following, and now we've built a radiomics platform. You just start with a segmentation of a tumor, and if you have segmented the tumor in one or multiple sequences, you have to co-register the different sequences to be sure that the different images are spatially aligned. And after that, you just compute a feature bank of features. So this is also radiomics, is a conventional machine learning approach in which you could use first, second order derivatives of the images at different scales, or you could use a wavelet transform in order to describe your image with multiple features. And if you have done that, you can do all kinds of data science approaches. You can try to group your images. And the idea is then, of course, that somehow this set of feature factors is related to the underlying tumor subtype, or perhaps it's related to the outcome to therapy. So increasingly, in all our work in the hospital, we start to collect these data sets have them go through this radiomics pipeline, and we follow patients up over time to see what is the information contained and how it links to interesting outcomes. An example of that is in gliomas. In gliomas, there is a subset of the patients, it's about 10 to 15% of the patients that have a glioma, a brain tumor, which has a genetic defect in chromosome 1 and 19. They call it 1p19q code deletion. And these patients have a much better outcome than patients who don't have a tumor with this genetic mutation. So this is something at the moment you can really only find by doing a biopsy, but it would be very interesting to see whether by only imaging you could also be able to perform this, because then you don't need an intervention. And this is really impacting directly quality of life of patients, because the outcome of this patient group is so good compared to the other people with this tumor that you may actually end up not undergoing surgery. So if you could do an image-based prediction, you could prevent both the biopsy and both the surgery in a subset of the patients. So we actually made a challenge out of this, and it was very interesting. We had a neuroradiologist who was sure also that she, in this case, would be better than any algorithm in order to be able to differentiate these two types of tumors. So we trained this network, and this was a conventional radiomics approach. We now have similar results with a deep learning implementation. But so we trained with only 81 cases. It was a single center setting in this case. We're now extending to multi-center. And we found that the accuracy of the algorithm outperformed our local expert neuroradiologist. We actually made a tool which was showcased at the RSNA, and we invited radiologists at the RSNA conference 1.5 weeks ago to also try this. And none of the people that tried to manually label these scans did as good as the algorithm. So also here you see the power of machine learning, and with deep learning we get similar results. So the statement I would like to make is, I think in the field of medical imaging for many years, we have tried to make the whole field of radiology more quantitative and more objective. And we've gone through the traditional route. And the traditional route is we take, and I think it's almost a similar slide as the one that was shown by Daniel Ruckert before. We take the data, we acquire them, we reconstruct an image. A priori, we define what features might be interesting, and based on these features, we perform some action or we do a diagnosis. It's quite a nice paper by Ji Wang in Archive, where he challenges this whole approaches and looks at how machine learning and deep learning makes it possible to go directly from data to features, or do image reconstruction through deep imaging, or go directly from the data to actions. So I think this is also something we could try to really investigate in our community, because we have access to our raw data, we have access to our reconstructed data, and we're collecting our predictions, because for many years we're already working on this concept of radiomics and machine learning in medical imaging. So one of the questions is, couldn't we indeed go to these end-to-end learning approaches, and wouldn't it be possible to directly go from the raw data towards defining a genetic subtype of a tumor or a prognosis of survival? So this is quite an interesting field, and I think it is very interesting to address it with all the complications we have in our field, that the number of data is limited, and that sometimes the labels are not so accurate or are difficult to obtain. So our next step is to go beyond imaging. So in the end, there's one patient, and we can collect more than only imaging data. We can look at metabolomics information, we can look at genetic information, and in order to do prognosis, we would like to combine information from different sources. And actually, in the genetic domain, they face similar challenges as in the imaging domain, that prediction is very challenging. I mean, the hope was that with genetic data, we could do a much better prediction of the individual to get a disease. But this overview actually shows you the extreme complexity to do prediction based on genetic data in case of Alzheimer's. What you see here are all the SNPs. So all the genetic variants that have been linked to an increased risk of Alzheimer's disease. More than 80,000 people, their DNA data through a GWAS have been linked to outcome to identify these. So this is really information that we have gained over the last couple of years. So we now know a number of candidate locations on the human genome that increase our chance of Alzheimer's. But unfortunately, apart from the early onset Alzheimer that is here, which is luckily very rare, some genetic mutations really increase your risk of getting Alzheimer's. So if your parents have this form of Alzheimer's, you also have a large chance of getting Alzheimer's disease, early onset Alzheimer's. But most of the genetic risk factors, A, are very common in the population, and B, only increase your risk of Alzheimer by a very small fraction. And there are so many of those, where we have identified more than 20, that it's very difficult to build prediction models on top of that. And we have to realize that the reason for that is that so far we're only analyzing these data with very simple, massive linear regressions. And that's my question a little bit to the community. Can we do better? Now we have much more data. Can't we not try to investigate the relationship between genetic data, environmental data, and outcome better now that we have more powerful frameworks? So imaging and genetics are already combined, and we gained some insight. So first things we've been doing in our population studies is that we have linked imaging phenotypes, like the size of the hippocampus, the size of the brain, the presence of white matter lesions, to genetic data to find genetic markers that are coding for abnormal imaging findings. And we actually find that sometimes this approach is statistically more powerful than linking genetic data to disease. For example, if we look at hippocampal volume, and hippocampal volume is decreased in Alzheimer's disease, we have found new genetic candidates that code for a smaller hippocampal volume. And actually these findings are making people look into the gene that is localized close to that SNP in order to see whether there may be that gene may play a role in the pathophysiology of Alzheimer's disease, because we don't really understand Alzheimer very well yet. Another thing we can do with imaging genetics is try to get insight into the enormous gap between the association you get in genetic studies. So if you have a genetic study, you relate genetic data to disease outcome, but you have no idea if you find locations on the human genome that are linked to disease, what is happening in the brain. But if you have these large studies like UK Biobank, and we're now actually running these analyses, I show results on the Rotterdam study, but we've been running these analyses now also in UK Biobank, we start to look at if you take a population and you take that portion of the population that has a SNP that is linked to an increased risk of Alzheimer's disease, then we look whether there's morphological differences in the brain between those two groups. So we have all kinds of techniques, registration techniques and segmentation techniques, to be able to see subtle differences in morphology in the brain. So actually you're trying to see whether there's morphological differences in the brain between someone who has a SNP that is linked to an increased risk of the disease and someone who is not. And these data we all put online, so it's sort of a library showing for all the genetic locations that we now know that are linked to Alzheimer's disease, where are they affecting brain morphology? And in this way we provide some insight to something which was just an association. Where is this SNP that is affecting the disease? Where is it affecting the brain? So I think this is a really very important resource to better understand the relationship between genetic data and the imaging phenotype. So I think the future, is bright. This is such a complex problem. The fact that all of us have a genetic makeup, which makes that we have a certain genetic predisposition of disease, combined with our habits, what we eat, how we act, what we're doing, eventually lead to what we look like, but also whether we get disease or not. The fact that we start to collect these large data sets with imaging data, genetic data, and environmental factors means that this extremely difficult function, how is our phenotype defined by both our genotype and environmental factors, that studying this function is, I think, will keep a whole generation of scientists busy. And I think actually the community like this community, when collaborating with people with domain knowledge, can have a major contribution. Because I think there is a big promise in addressing this question, having these larger data sets and having these more powerful tools in order to map input to output data. But this is really a challenging domain, and problems will not so easily be overcome. So what is the status, I think, now from my perspective of deep learning in medical imaging? What are the potential and challenges? So I think for the field of image segmentation, quantification, extraction of relevant biomarkers, it's simply state of the art. It is also still very difficult to really make impact. If you look in the radiology department, winning a challenge at MICI or at another conference, or being able to show that you have superhuman performance on a task, is not directly translating into hundreds of clinicians knocking on your door to have that solution. You really have to work on integrating these technologies in the day-to-day workflow and show that it actually has an additional value in clinical practice. And often clinicians use imaging information with other information combined, and most of our challenges are often limited to imaging data only. So there's a lot to do there still. But I think, on the one hand, that this field is a bit of a hype, the influence of deep learning on medical imaging. But I like the statement of Zerhouni, the former director of NIH, who had an opening talk at the RSNA. He said that the speed of change is perhaps overestimated, but the impact is underestimated. I really think this is going to be a key technology in medicine the coming years. And what is really needed, and there's potential, I think we should work hard to bring these people together. I'm very much also in the radiology community, and there's a lot of efforts in the radiology community to do a better job of measuring the fact that what they're doing has additional value. They have value-based healthcare. They try to measure things, follow things over time. They're starting to do more and more standard reporting. And in this way, actually, the routine clinical practice is improving such that labeled data can arise more and more from everyday clinical practice. And I think we have to bring our community and the community of radiology, and especially those visionary radiologists that work in that field together in order to collect data that can feed into algorithms that are developed by this community. And also, I think I'm really excited myself to see this very difficult relation between genetic data, environmental data, and imaging data, or what the role of machine learning can be there in the coming time. All in all, this will be disruptive. Hospitals are very much still in pillars. You have a pathology department, a radiology department. You have a lab environment. And I think this way of dividing a hospital in different sections will not hold. And I think within 5 to 10 years, more and more the disciplines that are doing diagnostics will merge. And I think hospitals will have diagnostic competence centers, and they will focus a lot not only on diagnosis, but more and more on prognosis and therapy selection. So I think this will improve the quality of life. This will make healthcare more cost effective. And I think the only way this can be done is by embracing data science, artificial intelligence solutions. I think in probably 20 years, we will not accept anymore that a diagnosis will be made without the help of AI. And I think in the field of imaging, because of early detection and prognosis, there's an enormous future for minimally invasive image-guided interventions, as for example, has been shown also in one of the earlier talks. So I think there's quite a bright future also for the field of radiology still. So I really think this is going to improve their practice. With that, I would like to conclude and ask a lot of people who've contributed to this. And if there's any questions, I'd be happy to address them.